Hello, and thank you for joining the podcast Emergency Minute. Your host is an emergency medicine physician who brings over 20 years of experience in healthcare. Dr. Parente will take you through some of the trending topics and challenges faced in the ER and all of healthcare. Join in the fight against misinformation, and don't forget to follow on social media at Dr. J. Parente. Now, here's your host, Dr. John Parente.
All right, welcome back, everyone, to Emergency Minute, episode 15. I wanted to thank everyone that checked in last time for episode 14, where we discussed some of the more interesting cases in my career. So thank you for that. I wanted to hear some feedback on that because that format, I do have a lot of other interesting cases that I have listed that I could discuss as well. I could probably have enough for another 2 or 3 shows. Just let me know your thoughts on social media or any social media platform at Dr. J. Parente. So today's episode is episode 15, What Really Happened with COVID. And I'm really excited to do this show because this is something that is near and dear to my heart. It's something that I had a front row seat and was down in the trenches every day for 3 years dealing with this pandemic, the response, etc. As a lot of you guys know, I am a director, so I am constantly involved with meetings, regionally, locally, at the hospital level, etc. So I think you'll be surprised at what I have to tell you. And I think it's probably the right for the American people to know exactly what happened. And my whole goal of the show is really just to connect the real world with the medical world. So that's what I'm going to focus on. Now, I have to be very careful. I don't want to call out hospitals, employers, etc. That's not my goal here. So I have to be very careful to do that. I also have to be very careful to navigate these political waters. COVID, the vaccine, etc. This has become a very polarizing issue, like many issues facing our country. But it's also nearly impossible to avoid some of these issues because some of these medical issues have been politicized. Just a quick disclaimer, this is just simply my opinion and observation of what happened. It may have been different in your state, your hospital, your country, etc. This is not representative of any hospital or organization. This is just my story, and it's really not meant to be told in chronological order, although there will be a lot of things that do happen in chronological order. All right, so let's set the stage. So we learn about this virus, this thing that is happening in China, and really nobody gives a shit. Okay, whatever. We're not going to deal with it. We have this egocentric mentality as a country that we're surrounded by all these bodies of water. Nothing can get to the United States, right? And if it does, it's just going to be a virus and we'll deal with it. Who cares? So the alarm bells really aren't going off yet. And furthermore, with the information coming out of China, you can't trust it anyways. First of all, there's not a lot of it. And anything that does come out, it's, communistic propaganda. You can't really believe it anyway. So I think, in the beginning, we were just kind of like, whatever. I think the tipping point for this was Italy. And when Italy got hit with COVID, it ran roughshod through the country as a whole. And you have videos surfacing on social media of these dump trucks backing up to hospital morgues and bodies just being dumped into these dump trucks. And, so the country goes on absolute lockdown. And we do have family there. I have a lot of family there. And so we communicated with them during the entire time. It was a very scary time. They could only go to the store. They could only go to essential places like hospitals and pharmacies or, essential jobs that they had. So it was no joke. And, so why do we care? Well, we care because these stories coming out of Italy, not just with these videos, they started running out of ventilators. They had rationed care. They started talking about how they couldn't care for the super elderly because they didn't have enough resources. So they were going to have to basically just take care of the people that were somewhat younger that still had life to live. That's a pretty scary thought. As a healthcare worker, me being a physician in the emergency room, I thought about that a lot when this stuff was kind of going on. And I'm like, no, that would never happen in the United States. We'll figure it out, all those things. So in the beginning, Italy had about a 10 to 13% mortality rate. That is extremely high, 10 to 13%. So to kind of give you some perspective, and by the way, mortality rate means if you get the virus, your chances of death. Essentially, that's basically what it is. So, most viruses are like 0.01% or 0.1%. They're very low. Some of the more aggressive viruses can get up as high as 1%, but still very low. Let's talk about a couple of famous bugs in history. And these numbers are all over the place if you do the research on this like I did. But Spanish flu of 1918 was anywhere from 3 to 10%. Smallpox was 30%. Ebola can be anywhere from 10 to 50%. And then the biggest one, obviously, bubonic plague, depending on what you read, 30 to 60% that wiped out a ton of people. We'll talk about that later. So Most viruses are very low, 0.01%, 0.1%. So they're very low. Now, obviously, there are limitations in mortality rates. What's the accuracy of a confirmed case? What's the accuracy of the data collection? What treatments may be available, for example, in the United States versus in an impoverished country in Africa? What are the patient's access to healthcare? Obviously different there than here. So I think, obviously there's some limitations, but Italy having a 10 to 13% mortality rate, this is when the United States hit the panic button, and I think rightfully so. All right, so let's pretend the entire country gets the virus and roughly 10% of them are killed. This would be 30 million plus victims. This would obviously be a humongous deal. So you're probably asking, for some perspective here, what pandemics, what diseases took out 30 million people? So, all right, let's look at this. So you had swine flu, which was about 200,000 people. You had the Asian flu, Russian flu, that was about 1 million. And then you have Spanish flu, which was about 40 to 50 million. And then you had smallpox, which is about 55 million. So what is the worst ever? Well, the bubonic plague, which was 200 million people. Now, spoiler alert, the COVID death toll is about 6.9 million. Now, you have to take this with a little bit of a grain of salt. There's been a lot of accusations of healthcare providers that had to put COVID as a diagnosis of why the patient died. Now, as a physician that does this sort of thing, sometimes it truly is difficult. So I'm going to tell you a story of a patient that we had that came in with an unresponsive episode and ended up getting a CT scan. We scanned the brain. There was a very large intracranial hemorrhage, so there was a brain bleed. The patient obviously ended up on life support, and we did everything we could, but at the end of the day, this patient ended up dying. Now, in the process of our workup and everything else, yes, we discovered that this patient had widespread COVID-19. Lungs were full of fluid and debris, very characteristic of that first initial wave, the most dangerous strain of the COVID virus. And we'll talk about that later too. So yes, this person died from a brain bleed. But one thing that we know about COVID is that it was a very much inflammatory condition. It did cause vasculitis, which means, inflammation in your blood vessels, things like that. It does predispose you to things like blood clots. We know that for certainty. So did this patient die from a brain bleed, or perhaps this brain bleed was caused from COVID? I don't know. I don't know that. And I'm not even sure how that person's death was classified. But the point is, sometimes there is a gray area and we honestly don't know the answer. But nonetheless, this is the death toll, around 7 million. And I think this is when the United States said we need to have a response here. And if you remember correctly, at that time, former President Trump was widely criticized for wanting to shut down the borders because of that fear. So let's talk about that U.S. response. It will be impossible for me to put into words the massive amounts of collaboration, efforts, the communication that took place at every level of healthcare. It actually was impressive to see. We began setting up incident commands at every hospital I worked at. We had daily, weekly, monthly calls with EMS, local hospitals, even regionally, nationally. You saw things like Cleveland Clinic and UH collaborating, which almost never happens. Hospital systems were talking to each other. What treatment protocols are you doing? What are you guys putting in place? There was a massive amount of communication that I actually really did think furthered healthcare, and that's a conversation for another day. One of the agencies that we worked with closely was the Ohio Department of Health, and at this point, we were being told that we need to be prepared to see a 300 to 400% increase in our ER volume. Now, to put that in perspective, that means instead of seeing our normal average, which was about 70 or 80 patients a day, they're saying we could see as many as 200 or 300 patients per day. Now, that is terrifying and also almost impossible to staff and prepare for. So almost every hospital I worked for, I think actually every single one, started building tents outside of the actual hospital. You have any idea how hard it is to build a second hospital outside an actual hospital? I mean, think about it. You have electronics, you have to deal with heating, you have to deal with wind, IT supports, staffing it. You have to deal with pharmacy. Well, what about respiratory functionalities? You're going to have the need for oxygen, possibly setting up ventilators, being able to do breathing treatments, administer medications. It still has to be clean. How are you going to clean this thing? So this is extraordinarily difficult. And every hospital that I know did this because we were all preparing for this massive surge in volume. The only time I've ever seen anything even remotely similar was back in 2009. I don't know if you guys remember H1N1, aka swine flu. Our volume was about 70s, mid 70s during the day. And then we had like a 6-week period where there was just this massive influx of patients where we were averaging about 100 to 110 every single day. Now, at that point, we had ownership of the company in the emergency room. We actually staffed an additional physician assistant that basically just worked inside the flu unit, which was in our CDU, which is our clinical decision unit. So we actually just had a 4-bed flew, in and out, because most people did just fine. But that's the only time I've really ever seen us as a healthcare system flex up outside of like the normal bounds of like healthcare. So that was kind of an interesting thing. But these tents existed at just about every hospital. So the obvious thought process was function the way we normally do, but when there's the massive surge in volume that was coming, then we just use the tents for maybe the patients who aren't quite as sick or the patients who can get in and out, or God forbid, if we needed to create some sort of ventilator unit with all these patients that are all on ventilators. This was the thought process of creating these tents. Now, what happens next? The first cases hit the United States. Now, there was a lot of ridiculousness when this happened. Contact tracing, and I'm not sure how familiar you are with this, but, I'll talk to you about the first patient I saw was at Hospital A, and, this person ended up testing positive, and we were all like, oh gosh, like that's the first case. Well, we had to find out who he was in contact with, and well, he was at a wedding in Chicago, and so then we were trying to figure out, who was at this wedding? Well, there were 250 people at this wedding, and well, how did he get here? Did he take an airplane or a car? And you could see how this is basically impossible to track this all. That's very ridiculous, in my opinion. I think, I don't blame us for trying to limit some of these things and try to gather as much information as possible. I remember coming home that day from my shift and I told my wife, I said, hey, we had our first case of COVID. She's like, just throw those scrubs away. And obviously we didn't. We just washed them the same way we washed everything else. But at this point, it's really not fair to blame healthcare workers. We were afraid. As far as we knew, this thing had a 10 to 13% mortality rate. Nurses and physicians in Italy were dying at an alarming rate, not to mention the patients as well. So this was a disaster to be set up. And we did start to see these disasters developing in New York and in the Pacific Northwest. Those were the two areas that got hit hard. Yes, hospitals were full. That is a fact. Yes, patients were dying at high rates in the beginning. That first strain of COVID was straight up nasty. Healthcare workers, nurses, working long hours in COVID units, in N95 masks all day. And yes, healthcare workers were dying too. Now, the radical left would have you believe that everyone was dying, and the radical right would think this entire thing is a hoax and it's just the flu. And as with everything that involves radical ideologies, what do they all have in common? Well, the truth is always in between there, right? It's not on either side of those things. But make no mistake, that first strain was nasty. I have a nurse that I respect the hell out of whose father walked into the triage room and said, I'm just not feeling well, got a little bit of a cough. They checked the oxygen level on the finger, was like 60%, and he was dead, unfortunately, a few days later. And the thing that was crazy about this, and I think this is where we learned a lot from how things were being managed in Italy, is that when you have a pulse ox on a finger prior to COVID, if you were like in the 90s, you're good. If you're in the 80s, unless you're like a very heavy smoker, COPD history, etc., most people in the 80s look like they are really having a hard time breathing. Respiratory distress. They're using their accessory muscles. They're oftentimes gray or blue. They look miserable. Their lungs sound miserable. What's crazy about COVID is that we would see patients every day that had oxygen in the 80s and were just sitting there talking to you completely normally. We'd see 70s or 60s and we'd check the pulse ox. Like, is something wrong? Like, is the machine broken? And this is something that we hadn't seen. Now I can tell you what they were doing in Italy. And, at first we didn't know any better. They'd see these oxygen levels and say, well, we have to intubate this person, put them on a ventilator and give them 100% oxygen. What we found after the fact is that this was actually killing more people because they weren't in that respiratory distress. They were functioning okay, even with lower oxygen levels. And we learned a lot from the mistakes that happened in Italy and said, hey, whoa, let's slow down on putting these patients on life support. Maybe they can, survive at a lower oxygen level and, continue to treat them in every other way fashion. Now, if they obviously start to decompensate, they go into respiratory distress or something like that, they start to have heart attacks, strokes, etc., then yeah, at that point you need to increase your oxygenation somehow. So I think that was what we saw that was very fascinating about COVID. But to get back to the story here, I have a colleague of mine that I also respect the hell out of that lost 2 grandparents and 2 aunts in less than a 3-week period. And remember, you couldn't do funerals at that time with anyone, and you couldn't even be with your loved ones when they were dying. We started FaceTiming for patients that had dying loved ones because you weren't allowed to have any visitors because they were trying to contain this thing, which you could argue all day long whether that's right or whether that was absolutely wrong. The one thing I want people to take away from this, and you hear a lot of this being politicized on social media and Twitter and things like that, was that, this pandemic was fake. It was a hoax. Like, that is so disrespectful to the healthcare workers that were involved, to the people that did lose loved ones. This thing was nasty. The first strain. We'll talk about the second and third and all that stuff, which were way more mild. But for the people that are like, oh, it's just the flu. It was not just the flu in the beginning. So let's talk about what happened next. What happened next was the thing that no one saw coming. The world shut down. The famous, or now infamous, 2 weeks to slow the spread. Everyone, for the most part, followed these shutdowns. Now, you still had your super spreader events like kids on spring break and things like that. But what happened was our volume tanked. We went from supposed to seeing, 70s, 80s patients per day, preparing to see 300 a day, to the 30s. We never saw anything like this. It was eerie. We sat around for days, for weeks, only taking care of relatively true emergencies. It was actually kind of cool for me in some regards because we actually treated patients that needed to be there. Now, that's a whole nother conversation, a whole nother podcast, but a lot of what we see in the emergency room is just people that can't get into their family doctors, people who want a work note, people who have, chronic pain and have nowhere else to go. People that say, hey, I've had this knee pain for a month. I'm going to go ahead, or for a year, I'm going to go ahead and get an x-ray today. So you see a lot of this in the emergency room. I always say this, that we're America's safety net, because when people have no place to go, they go to the ER. So this is where you're going to see things like the silly nurse TikTok videos that came out. And these people took a bath on social media. And I actually was in a conversation with a friend from Michigan the other day on Twitter. And unfortunately, the average person just doesn't understand what happened. And that's why I'm doing this podcast. But, he was just like, oh, these nurses, they just, all they did was they didn't do anything. They didn't do anything that was dangerous. All they did was make TikTok videos, and they're lazy and they're stupid. And it was just a very, unfortunately, uneducated conversation because he wasn't there. He doesn't know. It's not his fault that he's misinformed. But at the end of the day, yes, this is when the world shut down and we were just twiddling our thumbs in the air like, what's going to happen? Like, this is insane. And what's crazy is we obviously, we'd see some COVID patients come in, and when they did, they were extremely sick. And we saw some other things too, but even heart attacks, strokes, all these things that we normally see just seem to stop. And it's because the entire world just stopped moving. It just stopped doing things. People weren't going outside. People were afraid. People certainly weren't going to their family doctors. They weren't going and getting their colonoscopies or mammograms. All those things weren't even available. You couldn't go because unless you had an emergency, you couldn't go to the hospital. Most hospitals shut down surgeries. So if you had an ACL tear that needed to be fixed, too bad. Yeah, it's not an emergency. If you got a femur sticking out of your leg, then yeah, you're going to have surgery. This took over healthcare in a way that I didn't even think was possible. So as the whole world is dealing with this new pandemic, one of the things that we did see was everybody was fighting over cleaning supplies, PPE, masks, things like that. So you had the entire world scrambling to try to get more Clorox bleach wipes or hand sanitizer, soaps, things like that. And believe me, this impacted the healthcare system too. I remember one shift where we were trying to obviously use the cleaning supplies that we have, and we ran out and we couldn't get any more. And our suppliers were like, we don't know what to tell you. So we literally were sending nurses to various drugstores to see if they could find anything, Walmart and Costco's and the things that were deemed, essential at that time that were still open. And it was very difficult to find these things. Now, to kind of put that into a healthcare perspective, PPE. So, the PPE, the things that protect us, masks, gowns, gloves, those kinds of things. So now you have the entire world scrambling to try to get their share because they want this, obviously the easiest equation in business is supply demand. They want to have the ability to have some of this supply because when the demand gets so high, people could start charging more money. It's going to be harder to get these things. So hospitals became very protective over their PPE. Now, thankfully, this was the one thing I did see coming before it happened. I went to social media, selfish plug. Obviously, I'm very active on social media. You guys know that. I'm very grateful because I put out a lot of posts on Facebook and Instagram and some other things that, hey, does anybody have any N95s? Does anybody have surgical masks? Like we are running low and right now we're okay, but we're going to be in a world of hurt if we can't get some of these things to protect ourselves to take care of these patients. And so I did get a lot of people that shipped me some N95 masks and some gloves and also some surgical masks. So I'm extremely grateful for that. That was a crazy time. Now, every hospital, and I've talked about this before, they're not all created equal. So you have Hospital A is a terrific example of how not to do this. So they locked up their PPE like it was a room full of, big bricks of gold. And this room was not close to where we practice medicine in the emergency department. I mean, so we have a patient that comes in that needs to be intubated. Well, we did find out that when you intubate a patient, you're directly looking into the back of their throat to put a tube down their airway. This was the single highest risk for transmission of COVID from patient to doctor or healthcare worker because my face is basically in their face and I have to look down into the back of their throat, get up close and personal and put a tube down into their lungs. So this was an extremely high risk thing. Well, obviously, if I'm intubating a COVID patient, I would want to have an N95 at least, if not something more protective than that. So Hospital A lock these things up. Well, how do you go get them? Oh, well, you have to go track down the nursing supervisor. You have to have a 3-minute argument with him or her on why you need this. Then they have to walk about a half a mile over to a different part of the hospital where the golden bricks are locked up, and I mean masks, and then they can maybe give you a mask. And you'll be shunned and judged the rest of your shift because they can't believe that you had to ask for this mask. And this is how this went on. And so imagine if there's a patient that's dying in a room, because we get this all the time in the emergency room, where this patient comes in the door crashing and burning, and I'm going to find a charge nurse to try to get me a damn mask. That's actually what happened at one of the hospitals I worked at. And it's just preposterous that these hospitals functioned in such a manner that prevented patients from getting the care that they needed in a timely fashion. Or if they did, it was because I just said, screw it. I'm going to go in the room, put on a regular, mask, which is not nearly as effective. And then I'm just going to intubate the patient. And well, hopefully I don't get this thing. And that's what ended up happening more often than not. So it's interesting to see the different hospitals. Now you have Hospital B. That was a perfect example of how you do this. You have a supportive administration and setting an example for the rest of the world to follow. There's PPE all over the place. Reserves were plentiful, backup plans in place to get more, and fully wired hospital tent outside that's solid, well constructed, etc. Like different hospitals' responses to this was very different amongst hospital systems and individuals. So it's very interesting to see this. And obviously I'm not mentioning any names at all, but kudos to Hospital B because the way that they handled this pandemic was exemplary to a lot of the other hospitals in the region. All right, well, what about the financial impact? So when this all started, I told my wife, look, we're going to be fine. Everyone's going to need an emergency room. We have not needed emergency medicine doctors more at any point in our history than we do right now. We're going to be just fine. Let's go out and support the local restaurants, the people that need our help. We're going to, continue. We ordered restaurants all the time. We were constantly trying to support local businesses to try to keep them afloat. And what happened next? Everyone lost their jobs. ER docs, PAs getting furloughed, shifts getting cut left and right, massive pay cuts, massive lost income. A lot of physicians function on what's called RVUs, and this is basically a way to measure productivity. The more patients you see, the more money you make on your reimbursement, because whoever's billing that for you is billing, and obviously they're making more money. So it rewards doctors who do a good job documenting, or they take care of the sickest patients, or they see a high volume of patients. So, obviously people lost their jobs. I heard stories of physicians like delivering pizzas and driving Ubers and doing everything because so many people lost money on this thing, because the ER volumes all were cut by like 40% in some places. So what happens in a system like we're in Cleveland, so 2 hospitals that I know of went down from 5 docs per day to 4. And you're like, okay, no big deal. Well, it is a big deal, because that's 30 shifts per month that are no longer available in Cleveland area for one hospital. Then you have another hospital. Well, that's 30 shifts fewer as well. So now you're down to minus 60 shifts. And then another hospital closes and they had to have 2 shifts per day. So that's another minus 60. So now you're at minus 120 shifts. That means that there's less of a need for docs. And PAs are being furloughed, and PAs are leaving and going into other things. I had one PA that went into real estate. I mean, doctors are going to say, well, screw this, I'm going to retire. So you have early retirement. So there's just a less of a need for this. And so what ended up happening was these contract management groups, hospitals, et cetera, and to an extent, this makes sense. They pulled back their staffing big time. They can't pay for staffing at, 80 patients a day when only 30 are coming in. Like you're not going to keep the lights on. You're going to lose money. So I get it. But this became a big problem. And a lot of people don't realize this. I know personally, I lost my ass on COVID because I work a lot of hospitals and they no longer needed me. And if they did need me, I'd go there and I'd see hardly any patients and I wouldn't make any money at all. So this was a huge financial impact to the entire healthcare system. And yet, not to mention, workers, small business owners, etc. I mean, we had government overreach like we've never seen before. When restaurants could open, they could only have a certain number of people in the restaurant. You couldn't stand in a bar. You had to be 6 feet away from another table. Like they had all these other things. So this impacted, obviously there was a global impact, but I'm just referring to the healthcare system here because I think a lot of people don't realize that. So what happens next? Well, the country starts to slowly reopen. Volume starts coming back to the emergency room, but it's highly inconsistent, making staffing almost impossible. We had to be ready to see 50 patients in a day, but we also had to be ready to see 90. That's very difficult to do. We talked about the docs and the PAs still losing money. Staffing companies cut way back to try to survive. And then what happens? Another wave of COVID hits. This time it's a variant. Now there's different variants of any virus. Specifically for COVID, there was, alpha, then beta, then delta, then Omicron. As they mutate and they have more mutations, they typically become more contagious, but less lethal. This also makes vaccination accuracy very difficult. So we did see this with the mutations, thank God. Because what this meant was the next strain was going to be more contagious and more people were going to get it, but we were going to have a lower percentage of people die. Now, remember, we had tents. We expected high volume. Everything plummeted. And what happened? Well, we took down the tents. In fact, most hospitals didn't even use the damn tents. So now we have this Delta wave, which is way more contagious, less lethal, but still pretty nasty. Not as bad as the OG, but definitely much higher mortality rates than the flu, which is the common expression we often heard from the radical right. Oh, it's just the flu. No, it's not just the damn flu. So this is when hospitals truly became overwhelmed. So think about it. We just spent the last year cutting everything, cutting staff, cutting, oh my gosh, there's only seeing 30 patients a day in the ER. So the country starts to reopen. Thankfully, people are somewhat getting back to normal. So now you have your usual ER visits, right? But then you also have people who are entering the healthcare system for the first time because they were either fearful or they couldn't go get their colonoscopy, their mammogram, their elective surgeries, etc. And now we have Delta on top of that. This is the worst thing I've ever seen in my career. There was no place to put anyone. I remember being on calls, being the director, and I cannot tell you how many times I said, guys, we have to figure out a way to take care of the people inside the walls of this hospital. Because so many times community hospitals have the ability to send to a larger system. We're going to send you to Cleveland. We're going to send you to Toledo. We're going to send you to Akron. Well, when you can't send people places because everybody else is overwhelmed as well, then you have to figure out a way to do it at your hospital, which put us in some really bad spots. But that was the reality. And this is the story that the average person doesn't know. So how do you take care of these patients? Well, you have Hospital B that was exemplary in how they handled this. The hospitalists take care of the admitted patients. So when I admit a patient, they go upstairs to the hospital and they get cared for by the hospitalist. Well, in this case, there was no place to send anybody upstairs, so they stayed in the emergency department. That's called boarding. And I do have an entire episode, selfish plug, on the transfer and boarding crisis, which we still face to this day, just not to the level that we did back then. Now, you also have an example from Hospital C on how not to do this, because in Hospital C, they had to admit the patient and then care for that patient because the hospitalist would not come and see the patient or take care of them in the ER. Doesn't sound like a big deal to the average person, but let me explain it to you this way. If I walk into the emergency room and there are 28 admitted patients, plus I'm going to see 100 patients that day in the emergency room, how on God's green earth am I going to take care of the admitted patients, especially when that's not even my training, and take care of the 100 that come through that are going to be in hallways and closets and chair beds and waiting room beds? It's absolutely preposterous that Hospital C had the physician doing it this way. In fact, Hospital C would just say, you know what, we're just not going to admit anyone for the next 8 hours to allow the people that are upstairs to sort of decompress. Are you kidding me? What are we supposed to do in the ER? We're just supposed to just not admit anyone and just have people piling up in lobbies and in hallways and in chairs. And this is when patient care went to shit in the United States. Everyone was boarding. Boarding meaning admitted, but no place to go. Where can we send you? We can't send you anywhere. We saw things that I'd never seen in my career. We would take someone who was stable, or at least hopefully relatively stable, and say, look, you need to get back and see your surgeon at the bigger hospital system in Cleveland. That's where you just had surgery, 3 days ago. I can't send you there because they are completely full. They're not accepting transfers, and they're like on a 6-day wait list. Your fastest path to get there is for us to discharge you. You drive to the front door and you knock on that front door and you get seen by their surgeon, just like everybody else in that emergency room. This was preposterous what we were doing. We had to get creative and think of ways to transfer and move patients so that they could get cared for. The peak I saw in my particular hospital was we had 15 boarded patients. Keep in mind, we only have 18 beds, and that includes chairs. We had 15 boarded patients. 5 were ICU patients. Full ER, hallway beds, and then we started using random rooms in the emergency room, triage, or even in the waiting room. There's another hospital on the east side of Cleveland that basically ran their ER from the waiting room, from the chairs in the waiting room, and did this for a while, actually. And just to add fuel to the fire, just about every other aspect of medicine, they just kind of wash their hands of any patients with COVID. If you're a family doctor, you don't see COVID patients. Go to the ER. Pediatricians, they wouldn't admit patients with COVID. They wouldn't see them in their office. Instead, transfer to a ped center. Want to get a COVID test? Sure, but not at your family doctor's office. Go to the CVS or go to the ER. We actually had a nurse that had to be staffed just responsible for swabbing patients that had COVID symptoms outside. So they would run outside and there were 5 or 6 parking spots. They'd swab somebody and then come back inside. And we had this whole process that we would call them with the results and all this other stuff. And a lot of those patients obviously spilled into the ER if they were feeling ill or, to the point where they had to be seen in the ER. So we were seeing this surge in volume. Now, what about nursing? So nursing obviously became a very critical part of how we were going to deal with this. So I have nothing but respect for nurses. Anyone who's ever worked with me in my entire career knows that. I started off as a nurse's aide, so I have nothing but respect. Anything that I say following this is just my observation of what happened. But these nurses were heroes during this entire ordeal. And so if you think about this timeline, so you prepare for this massive volumes crash. So the RNs leave the workforce and they become NPs. They go to other departments. A lot of them go into aesthetics or med spas. They go into real estate. They retire early, whatever, because this was not a sustainable model. Well, then Delta hits, right? And so now there's this massive need for healthcare workers all across the country. So what happens is the nurses are getting paid insane amount of money, unsustainable rates that could not possibly make it, and the healthcare system would collapse. However, at the time, they started traveling to chase the dollar. I don't blame them one bit. If the same thing happened for emergency physicians, I'd probably do the same thing. So this was good for the individual nurses. They were making some cash. Hey, there's demand. They need us. This is cool. This is great. But this is honestly one of the worst things that could have ever happened to the healthcare system, not to the nurse, but to the healthcare system as a whole. This destabilized nursing across the country and the entire workforce, and this is still a massive problem today. I still can't transfer anyone, not because of beds, but because of nurses to take care of the patient in the bed. All right, so let's kind of shift gears here. I want to talk about a few parts of the pandemic. I'm going to touch on testing, the vaccine, and masks, government shutdowns as well. So this is going to be a little bit more fragmented, but let's talk about testing real quick. So why are we testing? Like in the beginning, it made sense. We had to kind of figure this thing out, but we're, years later, why on earth are we testing them? The PA that I work with, my BFF, shout out to Jansen, we used to joke and say, the strategy for COVID is basically to test them until they turn positive and then test them until they turn negative. And that was the thing, because we'd have people that would come in and be like, well, it's a negative test. I still don't feel good. They come back 3 days later. Well, I still don't feel good. We test. Oh, you're positive now. Okay, congratulations. You have a virus. And then like a week later, well, I still don't feel good. Am I contagious now? And then other doctors were like testing these people a week later. And, oh, you still have the antigen, so you're still contagious. And then they test them 5 days later. I mean, these people get like 5 tests. It's like, what the hell are we doing? And by the way, up until a few weeks ago, hospitals were still testing all admitted patients. And if you can tell me a scientific reason why we're testing patients that are having, gallbladder disease or something else that are just being admitted for no reason, and I will listen to you, but I can tell you that the word that you're looking for is money. And that's a terrible thing, in my opinion. So, but think about this testing. This testing prevented us from traveling. It prevented us from getting into or out of countries. This presented huge barriers to patient care. Till this day, I can't send a psych patient to get admitted to a psychiatric hospital unless they have a negative damn COVID test. You got to be kidding me. So what if they're crazy, they're psychotic, they're suicidal, they need a psychiatrist, they need to be on medications and have a medication adjustment? You can't give them that care if they have a positive COVID test, whether they're symptomatic or not, and have stable vital signs? You got to be shitting me. Come on. That's what's happening now. It's still a barrier. Some hospitals are not even taking patients upstairs until that COVID test comes back negative. It's absolutely asinine. And again, in the beginning, I get it. It was a very virulent strain, which means it was very dangerous in the beginning. But the strains that we're seeing now don't have near the mortality of what we saw in the beginning. All right, so what about the vaccine? Now, this is a very difficult conversation because for some reason, this has become extremely polarizing and very politicized. So I'm trying to avoid political issues. This is a medical issue that has become politicized. Now, what we talked about was in the beginning, having seen what I saw, crazy high mortality rate, far fewer people that were testing positive, that were vaccinated and then unvaccinated. Heck yes, I'd get vaccinated again with the knowledge that we had at that time, especially if I had any risk factors. The 3 things that we saw, or 4 things I should say, that we knew were going to kill people if they got the initial strain of COVID: obesity, a weakened immune system, old age, and lung disease. If you had any of those 4 things, 1000% you should have been vaccinated when it became available. Now, that being said, boosters, this raises into a different set of questions. We now have plenty of data that if you've had the vaccine and you've been infected with COVID at least one time, your immunity is very strong. And recent evidence would actually suggest that if you've had multiple boosters, your infection rates actually might be higher. So there's too much conflicting data right now for me to make a statement on boosters, yes or no. I will tell you, I am not getting any additional boosters with the information I have in front of me today. I will tell you that I did get vaccinated and I did have, I think about 2 or 3 boosters, over the years. I've lost track. But that being said, I'm not getting one right now until I see something that's more definitive that shows that this is going to be somewhat beneficial. Now, let's talk about kids. Why on God's green earth were we pushing this vaccine on kids? Yes, I am a 100% supporter of vaccines, of science, of polio, measles, tetanus, all the things that we do. Absolutely. There are mountains of evidence. Even the flu shot is life-saving. So I don't understand why we push this on kids, however. COVID never impacted kids, like hardly ever. Yes, there were some rare cases out there and you heard these stories and things like that. And even like the big pediatric institutions will tell you like, yeah, the ones that were like drawing from multiple communities eventually did get it. But in the beginning, this really didn't affect them. And the original COVID strain, thank God, really didn't affect our children. With Omicron, yes, kids started getting it. And it was basically like the flu. Kids would get it for a couple days and then they would be fine. The bad news is all of this conversation and all of this cramming this vaccine down people's throats is going to reduce parents from wanting to do the usual vaccines like the flu, things like that. And we're going to see this. This is going to start to rebound as we go forward in healthcare. And it really hasn't hit us that hard yet, but we're going to start to see things come back that were killed long ago because people are going to start to distrust the medical system, and rightfully so to an extent. And this vaccine issue is going to become a bigger problem. We really didn't use evidence-based medicine. We caused the entire world to challenge us, question us, and doubt the healthcare system. And, you know, we have data that these kids don't need the vaccine. We have data that boosters probably make you more likely to get COVID. And yes, we have data that showed that some people develop blood clots and myocarditis from the vaccine. That's a fact. Now, you know, the other side of that argument is, well, if you get the virus, you could also get myocarditis and also get blood clots as well. That's 100% accurate. So this really should be an individual discussion with your physician. There's a lot of conflicting data out there right now, but I wanted to at least make sure that we touched on it. What about masks? Here we go again. Very politicizing conversation. For one thing, to people to understand is how this works. The virus is extremely small. To give you some perspective about the size of the virus versus a pore in a normal surgical mask, it would be like a mosquito flying through a wired fence, except the wired fence, the little hole in the fence, is 14 yards wide. So that mosquito flying through that would be, you know, very easy to make it through the wired fence in that sort of example. Now, the thought is, hey, you know, the virus in order to be transmitted has to be on a living cell. So if I am at Home Depot and I cough directly up into the air and some of my cells go with the viral, you know, particle into the air, because I'm not wearing a mask, then someone that's walking down the aisle could inhale, or this person standing next to me could inhale, get the virus inside the cell into my body where it can then infect other cells. And that's kind of how this works. So there is some thought that, you know, okay, the virus obviously isn't going to go through the mask because it's such a tiny thing, but could some of the cells, the clump of cells that comes out when I cough into the air, could that get through that pore on the mask? And that's where the question is, okay, maybe there is some validity to wearing a mask if you're coughing droplets all over the place. And I think this is where we need to say, okay, let's look at evidence-based medicine. So there was a Cochrane report that was published in January of 2023 that demonstrated that there was no evidence that masks did anything to slow the spread or reduce mortality, looking at both surgical and N95 masks. And they concluded that perhaps hand hygiene was one of the most impactful ways to reduce viral load in any of the mask mandates. Now, remember, you don't just get sick by having one viral particle that like enters your body. It's about reaching a critical threshold that ultimately gets you to a point where you have enough of the virus in you that you get sick. So the mask thing makes some sense, but we have a Cochrane report that basically says it's not going to change mortality. It's not going to change the slowing of the spread. So let's live our lives. Why are we mandating these mask mandates? Why are we doing this again, by the way? So that leads me into the other thing here, which is the government shutdowns. Now, I think when I'm speaking to my grandkids someday, I'm going to talk to them about how this was the biggest government overreach in U.S. history. Now, you look back at the 2-week shutdown, and personally, I kind of agree with what they did. I think they needed to say, hey, 10 to 13% mortality in Italy. They're running out of ventilators for people. We have to kind of see what we're up against, and we want to buy our hospitals, our healthcare workers some additional time to prepare. But boy, that's a slippery slope. I mean, it wasn't just 2 weeks, right? I mean, are Michigan and California even open yet? I say that jokingly, but they were closed forever. You know, the ultimate give the government an inch and they take a mile. Well, our government took about 10,000 miles. You know, you empower the government to completely ignore constitutional rights for people. That's a slippery slope. I mean, you got people in Michigan that, you know, were threatened to be arrested for planting flowers in their front yard. You had people getting tased walking through parks. I mean, this got out of control. And by the way, you had government telling small business owners, you don't matter. You have to define what an essential worker is. Well, what's an essential worker? Like Walmart, you're cool, but Bob's local store, shut it down. So, I think restaurants were nearly destroyed. First the shutdown, then the restrictions. Well, you can't stand at the bar and you have to have tables that are 6 feet. Like, why are we letting the government tell us this? And, my favorite one is you can walk through the bar or the restaurant with a mask on, but then when you sit down, you can take it off and then you can eat because that's science. Yeah, definitely. And of course, the conversation was, hey, waitresses and waiters, they're going to be just fine. Yeah, in all likelihood, they will, because they can go get $20 an hour unemployment with no sweats. What about the person that owns the restaurant? What's he or she supposed to do? Well, it doesn't matter. They have more money. Not necessarily. That's not true at all. So it's very interesting time that we had to look at this government overreach. And then you have, people getting back into the workforce. So when the company started to reopen, what happened? Well, the teachers' unions fought like crazy, and they were actually empowered not to return while the rest of the world had already returned. The teachers' unions drive me crazy to begin with, but this was just the icing on the cake. I think they're still out there. I think they'd still rather be remote. And all they kept doing was citing how they were going to get sick and teachers are going to die and they didn't sign up for this and healthcare workers did. And like, oh my goodness, like, what are we doing here? So this government involvement here, I think really changed a lot of things. And I think if 20 years ago, you would have told this story about this futuristic United States where they allowed the government to make all these decisions, I think 20 years ago, people would say, hell no, we're going to revolt against that. And what's crazy is there's not a lick of evidence that any of it made any difference. Look, I'm all for 99% of vaccines. There's a mountain of evidence out there like we talked about before, but forcing vaccination, wow, that's a really, really slippery slope. So whatever happens next, I don't know what that is and what other freedoms we will be giving up under the guise of a national emergency. What else will the government say that they can do because of this quote unquote national emergency? This is a scary conversation. All right. So for my conclusion, I want to talk about words that stick with me to describe the response to COVID-19. And the first word that I'll say is surreal. I can't believe how ready we were for this thing that never happened. But then when it did happen, we were so unprepared. The second word I'm going to say is sad. I think it's sad to see how many jobs and how much money was lost, not just because of the pandemic, but because of the shutdowns. The next word I'm going to say is greed. How many corporations hid behind COVID losses for reasons to cut staffing, run super lean, and then increase their corporate bottom lines that never made it down to the employee? It's still happening, guys. I got news for you. Disappointed. I'm disappointed in the medical system. It has been uber politicized. It has absolutely not followed the science, whether it be masks, boosters, shutdown, social distancing. Why are we still testing people? Why are we doing this 3 years later? My next word is shocked, because I'm shocked we're talking about doing this again. Are we really going to start doing these mask mandates again? Come on. Let's get past this. This is ridiculous. But I'd like to end on a positive note. My next word is going to be heroic, because the people that were in the trenches that showed up to work, the nurses, the physicians, the physician assistants and nurse practitioners, and then the people that no one ever talk about, the secretaries, the housekeepers. Shout out to the housekeepers that just showed up and just cleaned these rooms with these viruses that they didn't know anything about. And they were scared to death too. And what they did was truly heroic. The dietitians and dietary, pharmacy, people that showed up to the hospital to take care of everyone, to weather the storm, the ups, the crazy downs, the loss of income, the loss of hours, while putting themselves at risk, especially in the beginning, was truly something to see. And my last word is hopeful. I'm hopeful that knowing that in healthcare, especially emergency medicine, we just adapt, we figure it out, and we find a way to get it done. Because my ER nurses are total badasses, and I will go to battle with them any day. This is likely and hopefully the greatest challenge we'll ever face, and we found a way to take care of patients in a manner that I never dreamed was possible. All right, well, that's all I have for today. I thank everybody for joining me. Join me next week as I'm going to talk about obesity medicine and weight loss and why everything you think you know about weight loss is probably wrong. Sorry. Don't forget to leave a review on Apple, Spotify, Google, or your favorite podcast medium. And I'd like to ask each of you, if you did find this show helpful or if you found it interesting, please do me a favor, click on the share button, share it with someone that you know that may be interested in hearing some of the ins and outs of COVID, the vaccine, the shutdowns, the masks, and what really happened at the organic level of the hospitals. Because I think this is a story that had to be told, and I think it's a story that a lot of Americans don't know. So I would appreciate it if you did share. And as always, peace, love, and happiness to everyone out there. Cheers, everyone.
Thanks for joining us this week on Emergency Minute. Join us next time for more hard-hitting discussions on some of today's issues in healthcare. Don't forget to leave us a review on Spotify or follow on social media at Dr. J. Parente.